All right, I just got an amazing question in from one of the newest clients at Odd Experts who are starting to adopt the science and really the mindset behind the intentionality of every test we do during our diagnostic process, following our best practice system. So, question is this: just curious, why would you do otoacoustic emissions if a patient has a hearing loss that is greater than a mild hearing loss? Wouldn't you expect to show damage to the cochlea? Look, this is a great question, but it's actually, it's not following the order at which we do our testing, and it's not placing the right emphasis on the right test. So for starters, we all have to accept the fact that the audiogram is not an indicator of hearing loss. The audiogram does not measure the amount of damage in the cochlea. Okay, the audiogram actually only really serves two purposes. One, which is to correlate degree of hearing loss with increased risk of developing cognitive decline and dementia. I know that's a pretty mind-blowing sort of concept to a lot of people. The other is basically your starting point for where you set the treatment technology. Otherwise, it bears very little weight diagnostically. Remember what I've said, the audiogram is a reliable metric, but it's not a valid metric. Okay, so before we do the audiogram, that's when we do otoacoustic emissions, right? So we do our cognitive screening, we do our otoscopy, we do our tympanometry, and then we do otoacoustic emissions. And the intent of otoacoustic emissions is to confirm the presence of damage in the ear, right? It's to confirm that there actually is a hearing loss, okay? And 99.9 times out of 100, it's going to catch that patient, right? So remember the 5 symptoms for every patient, whether it be issues with clarity, hearing and background noise, tinnitus, sensitivity to loud sounds, and memory issues, right? So we talk this through with our patients. We know based on their symptoms that they have the pattern of somebody who has hearing loss. So now what the otoacoustic emissions does is it confirms the presence, right? And so that's how we present it to our patients. Something like, Mr. Smith, we're going to run a test now to confirm the presence of your hearing loss, or to confirm that you do have hearing loss, right? So it's a very simple test that looks at cochlear mechanics, which will be damaged: age, ototoxicity, noise, Meniere's. I mean, you kind of name it, there's going to be a problem. I know you naysayers are, oh, what about auditory neuropathy? What about, I understand that. And you will catch those things elsewhere, vestibular schwannoma, right? But the vast majority, the 99 out of 100, you're going to see that there's damage up front. Conductive hearing loss, you're going to catch it with the otoacoustic emissions also, right? That's for a different reason. But the point is we actually do it first as our yes, no, right? Sort of a binary choice of do you or don't you have hearing loss. When you look at our report form, which is not an audiogram, which does not have tympanometry results, which does not have your typical, right? Our form, our medical form that we hand to our patients, that we send to the referring docs, right? After the section on cognitive screenings, asks the basic question of otoacoustic emissions, confirm the presence of hearing loss, yes or no, right? Something simple like that. So hopefully that answers your question as to the mindset of when we do otoacoustic emissions and why we do otoacoustic emissions.